Hello everyone, welcome to another module on the renal system. In this module, we will talk about the different types of nephritic syndrome. Okay, I've already discussed the basic principles of nephritic syndrome in the lecture of difference between nephritic, nephrotic and nephritic syndrome. Okay, so let me just revise it again. What are the basic principles of nephritic syndrome? In nephritic syndrome, there is glomerular inflammation which leads to glomerular basement membrane damage. Okay, due to the damage in glomerular basement membrane, there is a loss of red blood cells and which causes hematuria. Okay, the protein lost is in the subnephrotic range, and if the protein loss increases in severe cases, it can even lead to nephrotic syndromes. What are the different types of nephritic syndrome? The first one is acute PostStreptococcal Glomerulonephritis. The second one is the rapidly progressive glomerulonephritis. Third one is IgA Nephropathy, also called as the Berger's disease. And the fourth one is the Alport Syndrome. The membranoproliferative glomerulonephritis is majorly a nephrotic syndrome. That means it's a combination of both nephritic and nephrotic syndrome. Hence, I will cover this in a different module. Now, let's talk about these four. The first topic that we have is acute post-streptococcal glomerulonephritis. It is basically caused by group A beta hemolytic streptococcal infection of pharynx or skin. Okay, so it is caused by group A beta hemolytic streptococcus infection occurring in pharynx or skin, and the findings of skin is called as impetigo. Is this clear? Now it majorly occurs in children, and the symptoms are seen 2 to 4 weeks after the infection. So it occurs in children by group A beta hemolytic streptococcal infection, and the symptoms are seen 2 to 2 weeks after the infection. Now it majorly resolves spontaneously in children, but can sometimes lead to renal insufficiency. In adults, it occurs very rare, but it majorly leads to renal insufficiency. In children, it occurs most of the time and rarely leads to renal insufficiency, whereas in adults, the occurrence is very low, but if it occurs, it can lead to renal insufficiency. Is this clear? Now, this infection is a type 3 hypersensitivity reaction. Now, what are the hypersensitivity reactions? I'll cover in the module of hypersensitivity, but just remember this is a type 3 hypersensitivity reaction. It presents with, what are the symptoms? It presents with peripheral and periorbital edema, that means edema in the eye, or cola colored urine, that is hematuria, and hypertension. Is it clear? So it presents with peripheral or periorbital edema and cola colored or tea colored urine and hypertension. Is this clear? Now what happens is there is positive streptococcus titers. If it occurs due to streptococcal infection, there is positive streptococcal titers. There is a decrease in complement levels due to consumption. These complements are majorly deposited in the mesangium, hence there is a decrease in the complement levels. Now what do we see in light microscopy? So in light microscopy, the glomerulus is enlarged and it is hypercellular. This is the common finding of all the nephritic syndrome. So the glomerulus is enlarged and there is hypercellularity. We can see in this histology that there is excess cells. Hence it is hypercellular and the size of the glomerulus has enlarged. The immunofluorescence is starry sky. Okay. and hence it shows a lumpy bumpy appearance. This is very important, lumpy bumpy appearance. You can look in this diagram. There is lumpy bumpy appearance of different kinds of deposition, that is immunoglobulin G, immunoglobulin M and C3 deposition. And this is seen in the glomerular basement membrane and the mesangium. So is it clear? There is granular appearance, which is lumpy bumpy appearance due to deposition of IgG, IgM and C3 deposition in the glomerular basement membrane and mesangium. So this is the basics of acute post-streptococcal glomerulonephritis. Now what do we see in electron microscopy? In electron microscopy, since there is deposition of these substances or these immunoglobulins, we see a subepithelial immune complex hump. That means in the subepithelial region, there is a deposition of immune complex which is appeared as humps. So is acute post-streptococcal glomerulonephritis clear? This is one of the most important nephritic syndromes. Now let's go to the next nephritic syndrome, which is rapidly progressive glomerulonephritis, which is also called as crescentic glomerulonephritis. Okay, this can progress to renal failure or renal dysfunction over weeks to months. So it can rapidly deteriorate the renal function in days to weeks, and it has a very poor prognosis, and hence it leads to renal dysfunction. Now, why is it called as crescentic glomerulonephritis? Because under light microscopy, we see crescent moon shape. Okay, the crescents, we can see these crescent shaped structures. Now, why do we see crescent shaped structures in light microscopy? It is due to deposition of fibrin and plasma protein. This is very, very, very important, and examiners like to go after this. So it is deposition of this fibrin and plasma protein which leads to appearance of crescent moon shape in light microscopy. Okay, there is also presence of glomerular parietal cells, monocytes and macrophages. So what do we see in light microscopy? Deposition of fibrin and plasma protein which appears as crescent moon shape. Is this clear till now? Now there are several diseases which processes may result in this type of pattern and may be delineated via immunofluorescence pattern. So different kind of diseases which leads to rapid progressive glomerulonephritis have different immunofluorescence and hence are distinguished. So let's talk about the first immunofluorescence pattern, that is the linear immunofluorescence. This is caused due to antibodies produced to glomerular basement membrane and alveolar basement membrane. So if antibodies are produced against glomerular basement membrane and alveolar basement membrane in Goodpasture syndrome, it can lead to linear immunofluorescence. Now, it is presented as hematuria and hemoptysis and is a type 3 hypersensitivity reaction. So, in Goodpasture syndrome, which leads to rapidly progressive glomerulonephritis, there is linear immunofluorescence, and it is caused because of antibodies against the glomerular basement membrane and alveolar basement membrane. Now, what is the treatment of Goodpasture syndrome? The treatment of Goodpasture syndrome is plasmapheresis. Now, what is plasmapheresis? I'll talk in the pharmacology module. It majorly occurs in young male adults. This is very important. The Goodpasture syndrome majorly occurs in young male adults. Now let's talk about the second one, that is granular immunofluorescence. The granular immunofluorescence, as we discussed, it occurs in post-streptococcal glomerulonephritis and diffuse proliferative glomerulonephritis. We have already discussed over here, this is the granular immunofluorescence. So the granular immunofluorescence occurs in PostStreptococcal Glomerulonephritis and diffuse proliferative glomerulonephritis. This I'll cover in Nephritic Syndrome module. Okay. Now one more point is, it is most common type of renal disease in lupus. That is, the granular immunofluorescence is also seen in lupus, which is connected to diffuse proliferative glomerulonephritis. Now let us talk about the last one, the negative immunofluorescence or the pauci-immune, in which there is no Ig or the immunoglobulin or C3 deposition. Now the major diseases which are connected to negative immunofluorescence are Wegener's granulomatosis, that is granulomatosis with polyangiitis, that is Wegener's granulomatosis, and Church-Strauss disease, which is eosinophilic granulomatosis with polyangiitis. There is also one more disease, that is microscopic polyangiitis. Now, how are these presented? In Wegener's granulomatosis, we can see C-ANCA. What is C-ANCA? C-ANCA stands for cytoplasmic antineutrophil cytoplasmic antibodies. What are C-ANCA? These are type of autoantibodies which are produced by the body against one of its own proteins, and hence it is diffusely present in the cytoplasm. Now, if with negative immunofluorescence we see a C-ANCA or PR3-ANCA, it is Wegener's granulomatosis. But if we see P-ANCA, that is perinuclear antineutrophil cytoplasmic antibody, it can be either Church-Strauss disease or microscopic polyangiitis, correct? So how do we distinguish between these two diseases? In Church-Strauss disease, it is associated with P-ANCA and the granulomatous inflammation, eosinophilia and asthma. Okay, these three triad, that is, I'll again repeat, granulomatous inflammation, then second one is eosinophilia, and third one is asthma, distinguishes Church-Strauss disease from microscopic polyangiitis. Is it clear? Now, what are these diseases? It will be covered in separate module. But you just have to remember how to distinguish these from one another. So, if it's C-ANCA, it is Wegener's granulomatosis. If it is P-ANCA with asthma, eosinophilia and granulomatous inflammation, it is Church-Strauss disease, or else it is microscopic polyangiitis. Is this clear? So this is all about rapidly progressive glomerulonephritis. Remember about these three immunofluorescence patterns. Now let us talk about the last two nephritic syndrome. Let's talk about IgA nephropathy or the Buerger's disease. Now what is IgA nephropathy? Episodic hematuria that usually occurs with respiratory or GI infection. When there is increase in the mucosal secretion, there is immunoglobulin A produced, correct? And these immunoglobulin A get deposited in the mesangium and hence leads to IgA nephropathy. Is this clear? So let us talk about the light microscopy. What is seen in light microscopy? There is mesangial proliferation. Okay, there is mesangial proliferation, and under immunofluorescence pattern, we can see IgA based immune complex deposition in the mesangium. As I told you, since mucosal secretion, that is episodic mucosal secretion due to some disease, that is upper respiratory tract infection or gastroenteritis, can lead to increased production of IgA, which can further lead to its deposition in mesangium. Is this clear? and hence we see IgA nephropathy or Buerger's disease. This is the most common nephropathy across world. Okay, this is the most common nephropathy. Now let's talk about the last nephritic syndrome, which is Alport syndrome. Now what is Alport syndrome? It is basically inherited defect of type 4 collagen, mutation in the type 4 collagen, and it is commonly X-linked dominant. Is it clear? So there is thinning and splitting of glomerular basement membrane, and this leads to various other problems in the kidney, and even since the type 4 collagen is also present in the eye and the ear, it leads to eye problems such as retinopathy, anterior lenticulosis, or it can also lead to sensory neural deafness in the ear. Hence, a person can't see, can't pee, and can't even hear a bee due to sensory neural deafness, due to glomerulonephritis and eye problems. This is majorly due to type 4 collagen defect, which is an X-linked disease. Now let us talk about the electron microscopy. In electron microscopy, we see a basket weave appearance. We see a basket weave appearance in the glomerular basement membrane. That is an irregular thickening in the glomerular basement membrane. So are you clear with IgA nephropathy and Alport syndrome? So this is all about nephritic syndrome. Thank you for watching this video. If you enjoyed the video, please click on the like button and do subscribe to this channel. Let me know in the comment section below which topics do you want me to explain. Thank you.